What we think should happen, and in fact what we're seeing in a lot of practice throughout the US now, is a much more selective approach to biopsy, particularly with the use of molecular markers, free to total ratio, the 4K score, the prostate health index, or the use of MRI. So instead of saying, oh, you've got a high PSA, I'll biopsy you, it's like, oh, well, you've got a high PSA, that's of concern, let's do some more tests and then decide to biopsy only if you're at increased risk of having a high-grade cancer. The other question, of course, is who we treat. The main harms from PSA screening is overtreatment. Yes, overdiagnosis is a problem. No one wants to hear unnecessarily you have cancer. That's traumatic for a patient. But that's not half as bad as having long-term urinary, erectile, or bowel dysfunction. So we can reduce overtreatment predominantly by not treating men with low Gleason grade cancer. And obviously for many years we were treating pretty much everybody with prostate cancer, and then it was, well, we wouldn't treat you if you had Gleason 6 disease, grade group 1, and met all these other criteria. Your PSA had to be low, and you couldn't have high stage disease, and you couldn't have too many cores involved, and the number of millimeters, and so on and so forth. And in fact, those don't really matter. If you have Gleason 6 disease, you can be put safely on active surveillance, and that would cut the amount of overtreatment by at least a half.